the way that the talk is structured is it begins with kind of the basics, and then we'll talk about the innovations and kind of all of the new things as we go through towards the end. So hopefully there's a little bit of something for everybody. And I'm very happy to have questions at any stage. And I have permission to tell this anecdote. It relates to my husband, so Keith's son. And being a prostate cancer kind of specialist, I said to him, you know, when he went past his 40th birthday, it might be time, Peter, for you to have a think about seeing your GP and having some screening discussions with them. And he said yes, that would be a very good idea, and he booked an appointment with his GP. And when he came home in the evening, I said to him, Peter, how did your appointment go with the GP? And he said, oh, very well, Fritha. I got all those vaccinations. And I said, what about the prostate check? And he said, oh, dear, I forgot about that. And so we've had a couple of goes at gentle encouragement on my part, and eventually he did get there. But if we go one slide on, from this one, this is a terrible stereotype, which is still true in our household. So quite happy to biff a shark on the nose, but not so keen to go and get checked out. And I know that all of you, not from my household, would be not like that at all, and going regularly for checkups. And that kind of well-man approach to health is something that I would definitely recommend to people. You know, a once-a-year checkup with your GP is a really, really positive way to approach prevention, essentially, of health problems. So as a general concept, I think once a year going to see your GP and talking over a well-man kind of approach to your health is a really good idea. So next slide. So just to explain a little bit about, you know, what my job is and how that might differ from others. I'm a medical oncologist, and what that means is that I deal with medical treatments for cancer. So essentially any kind of infusion or tablet or treatment for cancer that is not surgery or radiation. And clearly with prostate cancer, there are a whole lot of both surgical and radiation options. And so there's a kind of a team that needs to be involved in treating prostate cancer, you know, starting with the general practitioner, but also involving the urology surgeons, the radiation doctors and us. And then there's a whole lot of other people that can be involved in terms of just making sure that someone's health is really optimized. And so I sit there in the medical oncology sphere. We have some understanding of the other members of the team and what they do, but that's where my prostate cancer expertise sits. And that means that often I'm seeing patients who have had their cancer come back after initial treatment, or who need a more comprehensive approach where they need medicine as well as the other treatments to manage the cancer the best way. So next slide. So this is just, you know, one of those slides which really shows where the prostate gland is. I think people have pretty good awareness nowadays of where that sits, but sometimes just actually having a look at the anatomy explains why particular symptoms might occur with prostate growth or prostate cancer. Now, obviously, your prostate gland can grow just because it gets enlarged with non-cancerous tissue. So you can get these symptoms just with a non-cancerous growth in that region. But you can see, because it's sitting right there at the outlet of the bladder, you can see that the main symptoms that come from either prostate cancer or the prostate gland growing are that it can cause trouble with urine getting out of your bladder, and also with the flow in the stream. And so that's that basically is the source of all the trouble when people have prostate cancer. But obviously the thing with cancer is that it has that ability to divide and grow and to spread. And so prostate cancer can spread to involve other parts of the body, particularly the lymph nodes or the bones. And it's quite a hard thing to understand. Sometimes people will come and say to me, have I now got bone cancer, or have I now got lung cancer? But if you were to have a look down a microscope at the cells that would come out of those areas, they would look like prostate cells if the cause is prostate cancer. So a little bit like if New Zealanders go to live in Australia, they're still New Zealanders. When prostate cancer spreads, if it does do so to other parts of the body, it's still prostate cells, but just sitting in the wrong place. And obviously you can prevent that by having early treatment and having removal or treatment to the cancer where it starts in the prostate. But there's a proportion of people who will still have the cancer spreading and needing treatment, despite that. And so the next slide. So sometimes people talk about a Gleason score, and you would hear people, quite often, there's quite a lot of conversations that happen around prostate cancer, which can be quite confusing. So you hear people say, well, everybody has prostate cancer and it doesn't need any treatment, prostate cancer isn't a proper cancer. And that's partly because not all prostate cancers are very concerning. So as you accumulate birthdays, it is more common to get a prostate cancer within the prostate. But if the cells there are very like normal, healthy prostate cells, then they actually are listening to a lot of the body's policemen and may not actually spread or change in the way of a cancer very much at all. And so that's in comparison with some prostate cancers, which can actually behave in what we'd more say is a proper cancer way and be more aggressive and need significant treatment. And so there is this range within that whole diagnosis of prostate cancer of some cancers which are less concerning and some which absolutely need aggressive treatment. And so the Gleason score or ISUP group is a way of trying to understand those risks a bit better. And when you look at that score, the first number and the second number add together to give you the total score. And the reason you get those two numbers is that you can have multiple different patterns within the same cancer. And so, oh dear. I hope I'm not echoing for everyone else. So that you take the first score that you would get when looking down the microscope, and then the second score, and that adds them together to give you the total. So if the cells look pretty normal and pretty close to a normal prostate cell, they will get a 3. And a 3 plus 3 equals 6. So a Gleason 6 cancer, it actually very likely to grow only slowly, if at all. And those are the situations that people talk about in terms of the cancer not being as concerning. Whereas if the cells look very abnormal and aren't listening to the body's policeman at all, then that cancer might get a score of a 9 or a 10. And that cancer needs urgent treatment, otherwise it will grow. So the next slide, please. So screening tests are kind of the preliminary way. So if someone was concerned about urine symptoms, then they would go to their GP and get a prostate-specific antigen test, a rectal examination, and if there was concern, then going on to have an ultrasound and biopsy. And the biopsy is what would give us that Gleason score. And that's taken in combination with those tests to work out a risk. The PSA test is PSA is actually produced by normal prostate tissue as well as prostate cancer. And so if it's high, it doesn't necessarily mean that there's cancer there, but it is an indication that more testing is needed. And so the next slide. So, and then follow-up tests would be depending on whether there was concern about there being a cancer there. And if there was concern about a cancer, then people will often have a CT scan, a bone scan, or a PET scan, which is a special kind of scan that we'll see a little bit later on some images of. And that allows this cancer to be staged. Next slide. So, so then we work out a staging group based on all of those things that allows us to work out what kind of treatment is needed, if any, and also whether the cancer can be cured or not. And it's really important to know that even if prostate cancer can't be cured, there are many treatments which can control the cancer for many years. And the treatment improves all the time, and we'll see some of those treatments in a little while. The next slide. So, and this is just the risk groupings are based on the PSA level, how big the prostate was, and what the biopsy findings are, and then the stage of the cancer. Next slide. So I just wanted to mention a little bit about treatment. So one of the options, if the cancer is a Gleason score 6 or less, like we talked about before, and it's just confined within the prostate gland, is that you can have a thing called active surveillance, which says, well, if I have treatment, I might expose myself to side effects of treatment, like trouble with waterworks or trouble with potency, and so I am going to watch and wait and keep a close eye on things. And it needs to be done in a scheduled way. That's the active part of the surveillance. And so it's different from watchful waiting, which is just kind of not following a clear protocol and not looking to have treatment if something worsened. Active surveillance is doing a PSA every 3 to 6 months, having regular examinations and continuing with biopsies with the idea that if the cancer got worse, then you could have active treatment at that time. And then the next slide. So obviously if a cancer needs treatment, then there are options. And one of the challenges that we have is that often people will choose the option of the doctor that they meet. And so we'd encourage people to try and meet both a radiation doctor and a surgeon when making that decision, so that you can really understand the risks and benefits of both options. Because, you know, many times people who meet a surgeon go and have surgery, and people who meet a radiation doctor go and have radiation, and there actually may be differences between the approaches that could make one or other better for you. And so it's a really good idea if you're trying to make a decision about treatment to actually make sure you have an appointment with both before you come to your conclusion. And next slide. Obviously, if the prostate cancer has spread, and then we touched on this just before, there's a whole lot of treatment which is available. And despite the fact that we can't cure the cancer in that situation, men are controlling their cancer and reducing it quite often to a kind of a level of a remission, so no evidence of the cancer at all, for years. And there's a combination of different treatments that we use, both hormones, more novel and advanced hormones, and chemotherapy in order to do that. And we're getting better and better at targeting the cancer in that way by using information about the genetics of cancer in order to do that. So then the next slide. So that's sort of the background and the basics of everything. But I just wanted to talk about a few new developments, which might be interesting to people who have a kind of a broader scientific interest. So one of the things that you may have seen on the news is some new developments, a treatment called lutetium therapy. And lutetium therapy is just another string in the bow, basically, of all of those treatments we saw just before. But the idea behind this is it's a theranostics treatment. And so it's a targeted treatment, and it treats the cancer by targeting a biological marker that's specific to the cancer. Next slide. So what is lutetium? It's a very short range radiation. So it doesn't travel very far. So if you can deliver the radiation to the right place, it won't spread out from that place and affect other areas. So essentially it's kind of the opposite approach to, when you're using radiation for more destructive reasons. This is where you want the radiation to be contained and focused. Next slide. So we have a prostate cancer marker, which is on the membrane of the prostate cancer cell, and that's a prostate-specific membrane antigen, or PSMA. And we're using that PSMA as a target for this treatment. So next slide. And so you can see that that antigen on the outside of the cell there. Next slide. And then the lutetium is going to attach to that marker. Next slide. So it has a corresponding kind of dock. Next slide. And basically we'll go on there and attach and deliver the radiation where it's required to kill that cell of cancer. So next slide. And next slide. And next slide. So what's involved with lutetium treatment? Basically, they do a very special scan called a PET scan, and we'll see some images of those in a moment. And it gets given as an infusion into a vein. It all takes about 4 hours. And the cycles, so it's almost like giving chemotherapy in that the cycles get given 6 to 8 weeks apart for 4 cycles. So as I say, it's just another arm to our bow. Next slide. But these are the results that we saw in the original kind of feasibility trial that was done in New Zealand, showing good reductions in PSA tests as a marker of response. Next slide. So you can see the 4 cycles of treatment that are given and just the PSA reducing with each treatment and then kind of stabilising out at the end of the therapy. Next slide. So what you're looking at here, it's really important to get your eye in when you're looking at PSMA scans. So there are some tissues in our body which are normal, healthy tissues, but that they take up that PSMA. And so this person's standing with their arms above their head, and we can see their salivary glands around their face. Salivary glands always take up the dye. So where you can see around the face there, those red areas, that's just the salivary glands, normal salivary glands taking up the dye. But that red colour there tells you what the cancer areas will look like if they are taking up a lot of the dye. And then you also see the dye being processed by the kidneys and coming out in the bladder. And so you can see the bladder full of red dye. There's always a little bit in the bowel and the liver and the spleen. So that's where we're at the top of the abdomen. So next slide. So we can see here, though, that helpfully they've put arrows on the areas where we can see cancer. And then if you look on the after side, you can see that those areas, except for that one up in the by the right arm, have become quieter with the treatment. So that tells us the radiation was delivered to the right place and has treated those areas. So next slide. And next slide. But it unfortunately doesn't work for everybody. And so you can see the pattern here in a PSA where the treatment was not working. And this person, you see 2 blue arrows, 2 treatments is usually needed to see if there would be a response, and the treatment was stopped after that because the treatment was not working. And so the next slide. And so you can see, once again, the situation where particularly the lymph nodes and the areas of the cancer got more despite the treatment. And so we want to try and avoid that. And we try as much as possible to make selections of situations where we expect that the person would have more chance of response, but it's not possible to be perfect in that yet. And as the science developed, just recognising this is an extremely new treatment. The final stage research trials around this therapy were only published in June. And so we'll get more information about how best to choose people who are going to benefit as time goes on. Next slide. Yep, next slide. And the next slide. And next slide. And next slide. So next slide, if you go 3 along, please. So this isn't a cure, unfortunately. Sometimes the media do us a bit of a disservice, and they imply, because these treatments, you know, can be very dramatic on the scans, they imply that they're a cure. This isn't a cure. But it is absolutely an effective treatment that will help some men with prostate cancer as an adjunct to the other therapies. Things like hormonal therapy are still much more effective than this treatment. Hormonal therapies should be absolutely the backbone of treatment, but this is a good thing to have added. Side effects, as you can imagine, include dry mouth, because of course those salivary glands get a bit of treatment as you go along. Next slide. Next slide. So around about 50% of patients do respond to this treatment. Next slide. And if you do respond after 2 cycles, then it's longer before you need any more treatment. So patients might get sort of an 8-month period before they needed to have any other treatment for their cancer. Next slide. And next slide. Next slide. And keep going. We'll just skip over that because we've got a lot to cover. Next slide. Yeah, and so it is a very expensive treatment. At this stage, it's not funded. And this slide really tells you, you know, what's coming in the future. So theranostics, this is just one way of targeting things. There's a whole lot of other targeted treatments which might be possible. So the concept is you just find a marker which directs you to the cancer, and then you attach a treatment to that. And so, of course, this opens up a whole lot of other therapeutic opportunities for research. So, you know, you can pretty much use this for any cancer which has a marker that you can image and use that marker to deliver any treatment. So not just radiation, we can use it to deliver immune treatments or other targeted treatments. And so this is kind of like just a very big can of worms that's just now open. And so it'll be really exciting to see what happens in the next 10, 20 years with this kind of therapeutic approach. And so next slide. So other developments in cancer care I just wanted to mention, if we have time, is just immunotherapy. And this isn't as important for prostate cancer, but maybe more important for some other types of genitourinary cancer like bladder cancer, and certainly for other types of cancer like melanoma. And when we're talking about kind of innovations and developments in cancer care, it's really important to hear about immunotherapy. So next slide. But it doesn't, at this stage, it doesn't work so well for prostate cancer. We're trying to work out how to make it more effective. It works for about 1 in 10 men with prostate cancer. If you look at this picture, however, it just kind of shows all of the processes that are going on with a cancer cell. All of these areas around this ring here are areas that we can potentially target. And so you can see that there's going to be a huge evolution in treatments for cancer. given that when we're talking about immune therapy, we're just talking about that pink one there, avoiding immune destruction. So we have all of these other potential targets for the development of treatments all the way around that ring there. Next slide. Next slide. So, and these are some treatments that we already have. So, and I don't know why they always come up with impossible sounding names, but all of these are basically existing classes of drugs. So you can see that why medical oncologists are getting increasingly subspecialised, because all of this could be relevant even just for one area. And next slide. So what we're talking about there is immunotherapy, and that's a whole new line of treatment, basically adding on to all these standard treatments that we've had over the years. Next slide. So this here shows the cancer itself and how these immune treatments might work. So basically, it's kind of not dissimilar from what we were seeing with the lutetium before. So the immune cell has markers on the surface, which normally in a situation where a cancer has become hidden from our immune environment, it's almost like the cancer cell is wearing an invisibility cloak. And what these treatments do is they put night vision goggles essentially on the immune cells. So here we see a T cell, and the little red arms there are the night vision goggles, and all of a sudden it's able to sense the cancer cell, attach to it, and start to kill it. Next slide. And next slide. So they kind of show the cancer to the immune system so that the immune system is able to attack and kill the cancer. And so it kind of feels like the perfect treatment. You're not having to kind of put things that are not natural into the body. But unfortunately, one of the things that can happen with these treatments is that our bodies get overexcited and start thinking that pieces of us that are not cancer are cancer. And so one of the main side effects of the treatments is kind of getting an autoimmune reaction. They're not without side effects, unfortunately. Next slide. And so the names of these sorts of the drugs are pembrolizumab and nivolumab. You know, they just don't make those names any easier. And next slide. But this is why immunotherapy is one of the cancer treatments of the future. Basically in melanoma, it's really led to a significant change in prognosis. You can see here that some patients with melanoma on immunotherapy actually changing the nature of the cancer and staying well now for years. Next slide. So next slide. So we need to be finding these immune and other treatments for all of our types of cancer, because with this sort of treatment, if we can target more of those elements of the wheel and essentially just put more and more strings to our bow, what it opens up the possibility is that basically we can do to cancer treatment what was done to HIV all those years ago. So nowadays, when I ring an HIV consultant and say, you know, what is the prognosis for this patient with their HIV or AIDS, they will say to me that they have a normal prognosis. So they're not expected to have that limited by their HIV diagnosis. And I would really like to see that for cancer in the next decade. You know, ideally, someone will find a cure and I will go and become a florist, most happily. But at the very least, you know, I really hope for a situation where we can turn this more into a manageable kind of chronic illness, a bit more like diabetes. Next slide. So just a brief mention on COVID-19. We were initially very, very worried that COVID-19 would be a big risk to our patients with cancer. But it seems like actually, especially with prostate cancer, the hormone therapies may be partly protective, if anything, and that it is mainly just patients on heavy immunosuppression with chemo or patients with lung cancer who have more risk, and the rest of our patients can feel a little bit more relaxed. And the next slide. But it's really, really, really important at the moment for those reasons, as we're finding out the science, because it is all under evolution at the moment. There's been dramatic development in science over only 6-9 months, is to make sure that when you're reading things and looking at things that you do look at the source, because there is a lot of misinformation out there. You know, there was one site that I saw where they were suggesting smoking was protective, and I'm pretty certain I know where that came from. It certainly wasn't from the scientific community. So it's really important to check the sources of information as it comes along now, because it is evolving and things will change over time.
Right, thank you for that. I'll leave you all muted, and if you have a question, please indicate in the usual way and press your space bar or ask me and I can unmute you. So Terry, you're pretty quick with your hand.
Thank you. That was great, Fritha. Thank you. I've got 2 questions. The slide that you had where the dye was revealing areas on the body, and you had before and after shots. I wonder if that has potential as a diagnostic tool. Can you just comment on that?
Yeah, we're actually using it as a diagnostic tool. Not so much, you know, there's still a lot of relevant information, unfortunately, because a biopsy is not a nice thing to have, but still a lot of important information from biopsy. So most patients still do need a biopsy, but we are using it where there's, sometimes we'll get in a situation where we're not sure whether something is cancer or not, or whether someone might have 2 types of cancer, unfortunately, and you want to know which is causing the problem. We absolutely use that as a diagnostic tool for prostate cancer and say, well, actually, it's lighting up with that dye, so this is prostate cancer. And there are a few patients who are avoiding a biopsy. So if someone came along and their PSA was 200, and they had a PSMA scan showing up like that, then they may not need a biopsy. We could probably treat based on that. Yeah.
That's the second part. I've got information from my GP from 15 years ago about the way diagnosis is done. And he was saying, and this could be well out of date now, that when someone returns elevated PSA, it's never easy to decide whether to proceed to a biopsy. And he gave an example of a patient he knew of that had elevated PSA and went for a biopsy 3 or 4 different times. Each time the biopsy came back negative because he explained sometimes the cancer is very, very small and portion of the prostate, so that a needle going in can easily miss it. And so it's easy to get a negative result on a biopsy. And yet the needle process with the biopsy can be injurious to your health, and that's why they want to be careful about deciding whether to get the biopsy. Is that all up to date or not?
It is. So what? There are 2 or 3 things that come into that decision making. It's not always straightforward. So one of the things is the PSA trend. So the PSA trend can be more important than the actual number. So and that is something that I think our GP colleagues sometimes get tripped up. So I have a number of patients who had totally normal PSA values over the entire time that they maybe had been being monitored, but the PSA was going up in a sort of an exponential manner. So, so despite the fact that PSA still falls within a normal range, that PSA is a problem because of the change in it. Whereas if someone has a very, very enlarged prostate, it could be that there's no cancer within it as long as that relatively high level stays the same and doesn't change. Because typically a prostate cancer PSA, it will start to go up. So the first thing is to look at a repeat PSA and say, is this changing? Then the next thing that we have available now, which might be a bit different from a few years ago, is often we will ask for an MRI scan. So an MRI scan is not quite like that PSMA scan, but it looks very nicely at the anatomy of the prostate gland in detail. And so there are some things that can highlight that, especially within a biggish prostate, where lots of it isn't cancer, can highlight that there might be an area of concern. And then sometimes you can target that area when you biopsy. You have a higher chance of getting the right result. And then, yes, the third thing that we actually look at there is sometimes if we're still not sure, getting a PSMA scan, because sometimes the primaries will light up, and that is a very new thing to be doing that. But sometimes in our multidisciplinary meetings, we're talking about doing that if there's an uncertainty there. Yeah.
So, Graham Colley, you're next.
Okay, what sort of symptoms should one look out to in everyday life?
It's a really good question. So, and the thing is, just to realise that most of the time when you have these symptoms, it's not going to be cancer, but it should be checked out. So that's where I was kind of nagging my husband a little bit, you know. If you find that you're getting up more often at night than you used to be and going to the toilet repeatedly through the night, or you're finding that at the end of your flow, you're getting some dribbling, or the stream's not as strong as it once was, or you're getting, pain or bleeding or something in that region when you're urinating, you know, those things need to be checked out. The commonest thing will be that you have a non-cancerous growth of the prostate, but it is still really important to have those checked out. Yeah.
Thank you. Next question. Yeah, Philip King.
Thank you. My question is regarding radical surgery. Many years ago, my surgeon explained that, I'll try and remember exactly, he had been overseas, America, and he was promoting the idea of entering through the perineum rather than from the frontal attack. And it seemed to make a lot of sense. If you go through the front, for some gentlemen, you're entering through a 6-pack of beer, 6 meat pies, and a lot of other instructions dragging down his belt line.
Yeah.
What is the current procedure?
So there's a couple of different ways of having, and just remembering I'm not a surgeon, so I'm going to try and answer this, but so there's a couple of different ways that they would look at it now. So there's a radical open prostatectomy, which is what you're talking about, dealing with all of that. And then there is either a laparoscopic or robotic prostatectomy operation. And so doing the robotic or the laparoscopic operations tends to reduce post-operative pain and stay in hospital and increase recovery time. It isn't better from a cancer perspective, so it's not getting better cancer or quality of life outcomes long term, but it does enhance that recovery period, because as you say, you're not having a bigger wound and going through that whole, you know, process there. Having said that, you do need your robotic surgeon. Their experience is important. So it is really important, if you're managing a robot or a laparoscope, that your surgeon is what we call a high volume surgeon. So they're doing it all the time, so that they're, you know, can do it in their sleep kind of thing. So it's actually worth, if you're looking at those kind of procedures, asking your surgeon how many operations of that type they're doing in a year and choosing a high volume surgeon. Yeah.
Is it generally now done through the back or the front?
No, it's still done through the front. The biopsies is done is where that perineal approach has come in. So whether you had a biopsy through the rectum, the back passage, or a biopsy through the perineum. And so biopsying through the perineum is something that the surgeons will sometimes do with a template under an anaesthetic. It's a bit more comfortable having an anaesthetic for that procedure.
Yeah, thanks very much for that. Very complex. I had a swollen prostate many years ago. It was the days when it was a very bloody affair. And
yeah.
it was gruesome.
Yeah.
And, a little time later, with a later procedure, which was all right. What still puzzles me is why it expands in the first place, a healthy prostate.
Mm.
Why
Yeah, so that's a really that's $1 million question. So why do prostates expand over time? Obviously the benign growth of the prostate is a little bit different compared to the cancerous growth. So in terms of why do we get prostate cancer, we don't have a 100% answer for that. We do think that there is some common pathway between heart conditions and prostate cancer. And so what that kind of means is that maybe some lifestyle factors are involved there. So one of the best ways of preventing prostate cancer is following the Heart Foundation's guidance on healthy heart. So it's that Mediterranean diet and regular exercise, all of those things, maintaining a normal weight over our lifetime. But it's not as easy as just that, because there are some families where it runs in the family, and where, hormonal differences that we're kind of born with might contribute as well. So you can kind of have a perfect blameless lifestyle and still get prostate cancer, unfortunately. So we don't have a perfect answer to that just yet. In terms of the benign overgrowth, that's a little bit out of my field as to why that happens. I think it is the hormonal changes that occur with aging, that we just, yeah. So I would say birthdays are to blame on that. Yeah.
Okay. I'll keep extracting 1 year at each time then. Okay.
Yeah.
That's great. Firstly, congratulations on a very well prepared and presented document on prostate. I found it very interesting.
Oh, thank you.
But I've learned one new term, the Gleason's score. What is the relationship between that and PSA, which I'm familiar with?
Oh, yes. So that's interesting. So your Gleason score essentially refers to what the cancer cells are looking like down a microscope. What the PSA is a byproduct, a protein byproduct of a cancer cell. So I'll often draw a cancer cell looking a little bit like a car. And if you imagine that the exhaust pipe and the exhaust is PSA. So if there are more cars driving on the road, therefore more prostate cancer cells driving on the road, there will be more PSA. But that's where the trend is important, because some cars are clean and some cars are smoky. So if you have a rising PSA, then there is more cancer, but the absolute level of the PSA can vary from person to person and cancer to cancer. Interestingly, some cancers with very high Gleason scores, therefore making them the more aggressive, actually produce very little PSA. And so those are the ones that sometimes trap us. And that's why you hear sometimes people saying, oh, well, screening doesn't work, because you can be more likely to capture patients with Gleason 7 cancer, which perhaps is less urgent for treatment, and miss people with a Gleason 9 or 10 cancer because they may not be producing as much PSA for the amount of cancer that's there. but I am still a screening proponent. I think it makes a big difference and I would support it, but that's where the debate comes in, because it can be harder to pick up those more aggressive cancers. So basically,
how do you develop the Gleason number?
Yep, so you look down the microscope and you're looking for a pattern of how irregular do the cells look. So often there will be two different kinds of patterns. So there might be some cells looking really, really aggressive and some cells looking very like a normal cell. And so you're looking for the biggest volume. So if you look down and you see in this field of sample that I'm looking at, most of the cells look pretty close to a normal cell. So they've only got some features that suggest they're cancer, then they will get a score of 3. And then there's a few cells in there, only a few, but they look really, really aggressive. They look very different from a normal cell. That gives you a 5. And so you've got 3 plus 5. That will give you a score of 8 for your Gleason score. So if you look down the microscope and all of the cells look really wild and they're all the same, that will give you a 5 plus 5 equals 10, which would be the highest Gleason score.
Terry, you are allowed a second go.
Okay, it sounds like you can only do Gleason score with the microscope inspection on results of a biopsy, the material pulled out on a biopsy. And you mentioned earlier that with the other diagnostic tools, it's possible to begin treatment without a biopsy. Can you explain how you would get a Gleason score without a biopsy?
You can't, and so that's a vulnerability. Yep, so that's vulnerability, and oncologists always feel a little nervous about doing that, because we're always worried that there could be something unusual about the cells that we won't know unless we biopsy. So, but that's medicine, horses and zebras, right? So most of the time, we're talking about horses when we hear hoofbeats, and every so often it's a zebra. So we're always very cautious and wanting to make sure we don't miss any zebras. But occasionally in discussion with someone, we'd say, well, having a biopsy is not really going to meaningfully change what we do. So you can choose to have one to make sure that there's no zebras, but you don't absolutely have to. Yeah, but that is the problem, because also if you do want to take part, and we talked a lot there about upcoming research and new treatments, if you do want to take part in a research study, you will always need to have had a biopsy. And so, people who want to kind of maximize their options, unfortunately, we still need a biopsy.
Any more questions?
Bruce
Coe, you've got to go. Fresh.
Fritha, thank you for your presentation. I'd just like to not talk about myself, but 60 years ago, I had a Gleason score of 7 and a PSA of 4.2. I was recommended to have brachytherapy and radiation, which I did have. And the other interesting point, you talk about the healthcare team of 9. I reckon I had 3. So what I'm asking is really what would happen to me today? And I'm sure it's of interest to all of us.
So it's still a concern to me. I think that there needs to be a bit more of a cohesive approach to men's health, because I am worried that what you get offered in terms of a treatment team can depend on where and how you start your process, and I'm sure that I don't get it perfect either. So there's a way, essentially we need to needs assess people's scenarios, because all or any of that healthcare team could be relevant to someone, but not everybody may want to engage with those people. It's just a matter of making sure that everyone gets offered, and it's the offering that we're still not getting right. So sometimes people will, for example, have a prostate surgery, and they might benefit from meeting a sexual therapist and a continence physio before and after that surgery, or they may have absolutely no interest in that whatsoever, depending on their individual situation. What I'm concerned about is that it gets offered. I think some practitioners are really good at offering that, and I think sometimes we're not.
Yeah, well, just to finish on that, and I think it applied to our age group, we trust our doctors. So, you know, we say, okay, doc, whatever you recommend.
Mm-hmm. Yeah, and so that's where we have an obligation to try and be more comprehensive about outcomes that matter to patients. There's a thing that the International Oncology Association, ASCO, has developed called COPI, which is a quality program, and they have a wheel of outcomes that they've talked to patients and that they believe for particular cancer diagnoses are important to patients. And then you can audit your practice against, you know, did you offer those things to everybody? And these are the kind of initiatives that help us to get closer, you know, over time. So COPI is a pretty important program, and for prostate cancer, for example, it has a wheel that includes those sorts of important aspects for men, and it audits whether or not you've discussed and talked about those options. Yeah. Mm-hmm. But it's hugely complicated and changing all the time. And so that's the challenge, is like the information that there's this kind of possible common pathway between cardiovascular issues and prostate cancer is quite new. And so all of a sudden, I'm sort of saying to men with prostate cancer, you know, maybe you should go and have an exercise tolerance test and, you know, get on a treadmill with your cardiologist. That's all very new. So, you know, things change all the time. We can always do better.
Yeah, a couple of more questions if we want. Anybody got another question?
Alan, it's Bernie.
Bernie.
On the bottom left of page 2, I'm not sure who it is. It's on iPad 2. It hasn't got a name, and I'm not sure whether their hand is up for a question or whether they're just steadying the camera.
That's Gerard.
Gerard, is it? Yeah. Okay. Well, the hand's down again now, so I take it it's not for a question.
Right. Okay. Well, thank you. You seem to have answered all the questions. I just wonder, Fritha, why does a woman get involved in men's private parts?
Oh, I tell you, it's been a very strange journey to where I am at. I like continuity of care, and oncology is great for that. You get to meet people over many years. And so that's why I chose oncology. It's great to kind of get to know people properly over time. In terms of prostate cancer, actually, when I started, when I was a consultant in genitourinary oncology, medical oncologists didn't really do much prostate treatment because we didn't have a lot of treatment to offer, and that's, you know, there's quite a lot of grey hair under this hair dye, but it's still not that long ago. So I was mainly treating kidney cancer and bladder cancer, which has a sort of a more even split. But along this decade, prostate cancer has become a huge part of what we do because there's been so many new treatments, which is exciting. So I've ended up with the gentleman by default, but I wouldn't change a thing. It's fabulous.
Right. Thank you. Well, having 38 people watching today is an indication of how interested we are in the subject. So thank you on behalf of our members for the effort you put in preparing a presentation for us, and what's more, fitting us into your very busy schedule. I'm sure you're in demand. So please join with me in thanking for the
thank you very much. It's a pleasure, and very, very glad to be with you today.
Thank you.